Okay, so before starting the session, people who are joining, please rename their name because we want to take the attendance for the certificates. So please don't keep iPhone, Vivo, Lenovo, anything. Just put your full name there so that will be easy for us to record your attendance. So, good afternoon, everyone. On behalf of OCI, I warmly welcome you to the third and the second session of our Cataract Awareness Month educational series. In the last session, we have explored the role of optometrist in, pre-op and the post-op assessments. And today we will learn in this interactive panel discussion, which will be basically focused on the referral decision making. So, as we all know, that timely and appropriate referral is one of the most important contributions optometrists make in the cataract care pathway. However, referral decisions are not always straightforward. The factors such as patient coexisting ocular conditions, systemic health, visual needs, and patient expectations often, they influence clinical decision making. So, through today's discussion, we aim to explore practical approaches to managing these challenges and, strengthen collaboration between optometrist and ophthalmologist. So, we are privileged to be joined by an esteemed panel of experts today who bring diverse perspectives. So, our panelists today, let me just give you a brief introduction. Our panelists for today, Mrs. Sharanya Balasubramaniam. She is distinguished optometrist, educator, and community eye care leader with over 25 years of experience in clinical practice, teaching, and public health optometry. She is a principal and academic director of Achyuta Institute of Optometry, Erode, and she serves as the managing director and consultant optometrist at Achyuta Eye Care. She's a graduate of the Elite School of Optometry and holder of advanced qualifications from the United Kingdom. Ms. Sharanya is recognized for her contributions to pediatric optometry, contact lenses, and community eye health. She has led large-scale vision initiatives, benefiting thousands of children and has received numerous awards, including Dr. P.P. Satnam Jayalakshmi Award for Best Optometrist, OCI Jaggi Award for the Best Optometry Contribution, and the Dr. Abdul Kalam Woman Achiever Award. So, welcome, Sharanya ma'am.
You.
And we also have Dr. Samina Zamindar. She's a founder and chief medical director of Zamindar Microsurgical Eye Center, Bangalore. She is highly respected comprehensive ophthalmologist and cataract surgeon with a strong commitment to quality and patient safety in eye care. She serves as the state of head of the Women Ophthalmic Society, Karnataka. She is a member of the Adverse Event Committee of the All India Ophthalmological Society, which is AIOS, and contributes to the International Medical Director Council of Seva Foundation, USA. She is an accomplished leader in healthcare quality. She is a founder of I for Quality, a platform which is dedicated to sharing and promoting best practices in patient safety and quality eye care. Dr. Samina has received the Young Quality Achiever Award from the Consortium of Accredited Healthcare Organization and currently serves on its governing council. So, welcome, Dr. Samina.
Thank you so much. Such a pleasure to be here.
Yes, sir. Yeah. So let's start with the discussion today. So I'll just give you an outline. We'll have few questions with both of you for the discussion over, referral pathways and what is the optometrist role. And then we'll have a quick yes or no questions on the patient scenarios. And the last is a rapid fire round where you have to, quickly answer and choose your option among the given options. Okay. So let's start with the discussion. So I would like to start with Dr. Samina. Dr. Samina, what are the, there are different school of thoughts for the, referral pathways. So when patient comes to an optometrist, some optometrists tend to refer early, while some, they want to wait till the patient is suffering from the functional vision loss. So what are the most common reasons for the inappropriate or delayed cataract referrals, and how can optometrists improve those?
I will go to the answer of this question, but first I would like to reinforce the fact that I am a great vocal advocate of optometrist in India, and I feel that optometrists play a very important role in preventing avoidable blindness. And I always feel that we are underutilizing the potential of optometrists. So kudos to all of you, and please do not give up. Always work towards, uh, you know, being a part of this important work, what we do, reducing the burden of avoidable blindness. So we have also formed a platform to incorporate optometrists in the mainstream conferences at ophthalmology societies also. And we have started advocacy in those areas. So thank you. I'm very glad for this opportunity. Now, coming back to your question, that what are the roadblocks for referrals? See, there are some age-old myths about cataract surgeries, and those myths might be there amongst, definitely they are there among patients. And not that patients in rural areas, patients sitting in Bangalore, I practice in Bangalore, and I get a patient coming in saying that no, but shouldn't I wait till my cataract becomes mature? So first, we have to introspect our own mind and say, hey, you know what? Am I comfortable referring a patient with 612 vision um, for cataract surgery? Is it really needed? Will this patient really benefit? Will the quality of vision improve? Because for the longest time, cataract was operated only when it became mature. We know the reason why, because the surgery type was different. Now the surgery is done with the most advanced micro incision surgery. It's bloodless, sutureless. It is the safest, the commonest and the safest surgery done in the world. And the results, the outcomes are close to 99.99%. Even infections is 1 in 10,000. So the chances of somebody losing eyesight because of cataract surgery, the odds are really, really less. So we need to be confident in our own thinking that yes, if I refer this patient is not going to come back and say, hey, you know what, you referred and see, I've lost my eyes or I've got less vision than what I got before. After saying that, I would like to say that
நீங்களே மேக்ஸிமம் வேணா ட்ரை பண்ணுங்க. Don't leave.
Yeah, sorry for the interruption. Yeah.
No problems. WHO itself has changed the kind of its benchmark. Now it says that for effective cataract coverage, we need 612 vision. It was 618 just last to last year. Now it's 612. So any patient 612 or less can be easily referred. Even if a patient is less than 612, if the patient is having glare during night driving, is an active worker, active professional, has issues in no in their job is affected, cannot see the television, cannot see the desktop, cannot work with the smartphone, and cataract surgery can be done. It is also done as a refractive surgery now, right? But always, of course, we'll come to a detail talk about what are the boons and banes of considering that as a refractive surgery later. But yes, I
Yeah.
would say that first of all, as optometrists, I would want each one of you to be confident that cataract surgery has come a long way. Gone are the days when cataract surgery was the third largest cause of avoidable blindness,
Yeah.
right? So that, but people still have it in their memory, you know. So we have to be very clear about our counseling techniques, that how are we going to counsel, and it's for the good of the patients, that what we are going to explain, and what we have to educate them about modern cataract surgery. Once that is done, the referral becomes easy and it is timely. We don't want to send patients earlier on also, you know.
Right. Right. Yes. Yeah.
I hope that answers the question. Yes.
Yes. Yes. Definitely. Thank you for that. Yes. Moving on to you, Sharana ma'am. Okay. Yeah. So you have, Achyuta is involved in a lot of outreach programs, and even you are actively, doing all these outreach programs. So what are the most common barriers, optometrists encounter when referring patients from these outreach programs or the camps, and how are these addressed? Because many of the time we have seen that, these referrals are not gone to the exact location where they want to
I
be.
know.
Yeah, so how do we address these problems, and what would you think about it? Yes.
Thank you for the question, Harshada. That's a very interesting one, actually. I think the biggest challenge when you want to send a patient from the outreach to your base hospital or to wherever, I think, is the fear factor. They're still worried about losing vision, not getting adequate vision, not getting a proper surgery done compared to what they would get if this was a paid cataract surgery, not getting the correct sort of a treatment when they go in. I'm not talking about treatment as in medical treatment. I'm talking about reception and how they are treated at the hospital, because it is an outreach, either a free camp or a very subsidized camp. Um, I think that is one of the main concerns that we actually come across. Other than this, what I would think of is most of them, at least we are practicing in a tier 2 city, a lot of villages close by. They don't have particularly sort of vision demanding tasks that they have to do. So they're quite happy, even if their vision is 618, 624, they're very happy with it, and they don't think that they need the surgery. They don't realize that the cataract has sort of gone past the NS2, NS3 stage. Surgery itself is going to become a little bit more time consuming, a lot more, sort of products to be used during the surgery, protective medication. So they don't understand that concept because they think, okay, I'm seeing well now, and why should I go have a surgery at the moment? The other big problem that we also have is they would have heard someone in the village who's had surgery and lost vision because of it. It can be any reasons. Come on, you do have complications. Walking down the street is a complication. You can trip, you can fall, you can have an accident. So this also has its own innate complications, but they would have heard that, and somehow human nature, anything goes wrong, we talk about it to about 100 people, but anything goes right, we don't even talk about it to the person sitting right next to us.
Right.
Financial concerns. They're a little worried because it's not paying for the surgery itself. The other hidden costs that they're thinking about, they have to come to the center, stay at the center. The attendant has to lose a day's work. They go back, they come back for regular follow ups, like the 1 week, the 1 month follow up. So every follow up means loss of wages on that day. And they're quite dependent on somebody else to bring them in. So if it's an older person, they have to ask somebody to bring them in. They need an attendant, and we have also seen a lot of migration for work purposes to other employment purposes to other bigger towns and cities away from home. So they cannot come here and sit here for however long is required for them to go through this. Um, Coexisting diseases. Most of them don't know they're hypertensive or they're diabetic when they come in for the first checkup. And unfortunately, when we pick up these issues and we point it out to them, a lot of them don't want to hear it. A lot of them,
Yeah.
want to kind of avoid the whole situation because they've been okay so far. Nothing's been happening to them. They don't realize these are all silent things that are happening in the back. Um, so how do we sort of overcome these? For the fear factor, losing vision and all that, we do have the optometrists who go for the camps. There are two people who specifically talk to people who have been advised surgery, sit them down, go through the whole process of what the surgery is and why we need to do it now. So we have a whole counseling session that happens over there. We talk about the benefits of the surgery, why you shouldn't be taking the risk of letting the cataract go up to maturity, what sort of vision they can expect at the end of the surgery. And if the camp has already been done in that area previously, we do ask some of our older patients who've already had surgery to drop in just to give us a hand. And they tell them, see, I've had mine done here and everything is going well. So success stories of previous patients. And sometimes what we also ask our counselors or the optometrists to do is they follow up with the family of the patients. They call the family members, they call them in for at least the counseling aspect of it. Improves, builds confidence, and then it sort of makes them to a position where they're making an informed decision. And we also provide the transport, like most hospitals do. We pick them up and drop them, so that takes care of the expenses for that day. But the loss of income is something that the patients do talk about and the attendants do talk about. So this
Right,
is
right.
kind of what this is our process, and I'm sure it's different, very slightly in every part of the country. But I
Yeah.
think the main concerns anywhere, I think, would be these. Because when I was at Shankanetralaya, I think this was what we faced there also. But the banner makes a difference. So once, they've seen the outcomes of the surgeries, that fear factor drops. But I think mostly the benefits and risks and the financial concerns. This is like the major challenging factor that we have to deal with.
To that, I think education also plays a very important role because, in the camps, as a student, I remember people asking, "Kuch drops se nahi hoga, spectacle laga do."
Ah,
I don't- yeah, so that kind of awareness or education, I think it plays a very important role.
yeah,
I would say yes.
yeah.
Yes. Moving on to you, Dr. Samina. Okay, beyond vision or visual acuity, what clinical factors do you consider when deciding if patient is ready for the surgery?
Okay. So it's a very pertinent question because it's not that there is a cataract and there is a
Yeah.
surgeon, surgery has to be done. Uh, Even if the patient is sort of suffering from vision loss, the quality of vision has dropped down due to cataract, there are certain conditions which we have to be very, very sure before we go in for a cataract surgery. So I would divide that into three parts. One is any ocular infections, like suppose if there is a watering of the eye, there is a chance that this patient might have some underlying necrocystitis, or that's a nidus of infection which is there, and we would want to clear that. So a patient with complaints of watering, I think you should say that, you know what, we might have to do a sac syringing, see whether there is some kind of regurgitation, something over there. We might have to treat the sac and that part first before we subject you to a cataract. If there is any mebomonitis, any internal hordeolums, blepharitis, that thing needs to be taken care of first. Third is that there is severe dry eyes, then that needs to be taken care of first, because after cataract surgery the dry eye is going to become a little more. The patient will become so uncomfortable. They are not. They will never be happy. So we need to treat the dry eyes also before we do this. That's about the kind of infections and all those things. Other thing is that suppose actively if the patient is having glaucoma and the pressure is very high, then definitely we don't want to do a surgery on a glaucoma a patient with a eye pressures, and you don't want to control their eye pressures and then do the surgery. If there is a vitreous hemorrhage or an active kind of a bleed in the retina, then we would want to control that by PRP laser, settle that down, and then think about the cataract surgery. Of course, there's uveitis also. We don't want to do the cataract surgery. We might be adding inflammation over there. So that's about the different conditions. Other situation is that if there is complete optic nerve loss, like almost, and then there is a cataract, not that it's a mature cataract. Mature cataract you might still want to remove because it can become a painful blind from a painless blind eye. But if there's an early cataract in an eye with the optic nerve is really compromised, you're really unnecessarily doing something, giving hope to the patient, because for the patient it's like hope. Okay, something is being done on my eye and maybe I'll get vision. So that has to be very, very clear that we are not doing such cases. At least let the cataract become significant enough, and then you can offer the cataract surgery for optic nerve loss. Similarly, for advanced corneal opacities and all, if you're doing something, you should be ready to do a triple procedure, with penetrating keratoplasty also, and then it makes sense. But just doing a cataract, and that also it can become a difficult cataract surgery because the visualization is so low. So I'll just repeat what I already said. I spoke about infections, I spoke about ocular conditions, and now the third part, which is readiness of the patient. If the patient is not ready right now, the patient is in a kind of a person who is 612 vision, is homebound, is able to manage all their things, and is not inclined towards surgery. Now, if you kind of forcefully kind of convince him to do the surgery, this patient, for the slightest problem after surgery, will be always complaining. I don't really want such patients to be sitting outside in my waiting area. You know, I would rather not do the surgery, rather let it come from them. Let them have some difficulty and then they can come to me and say, hey, you know what, I'm having a problem. I had a fall or something. Though ideally we say that don't wait for a fall to happen, do it before that. But if the mental makeup of the patient is very reluctant, then to convince the patient against their wishes and say, now, no, 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 for several reasons you should do it, that is something you should be careful. So, yeah, I think that this is what I wanted to say.
Yes, yeah. And I remember in last session, we had question from one of the participant that, in summer season, people usually, try to avoid surgeries, cataract surgeries, because they think that the healing is, due to the heat, it might get affected or something. So any thoughts on this, how to convince these patients on the surgery basis?
Yeah, you're right. In fact, I have just returned back from Nepal. I actually train in Nepal about quality and patient safety, and there is such a mismatch between the number of surgeries they do during other months of the year and then during their November, December, January. They're so full having, and the same center would be doing 100 surgeries now and then doing up to 300 surgeries a day during November, December, January. That's because people have not still ready to do the surgeries in rainy season, in summer season. So I think somehow a kind of a global awareness campaign. I'm looking at OCI to do that, maybe to do have a global awareness campaign about cataract surgery is safe, and do not, there is no good season. Today, now is a good season if it's going to help you. Yeah.
Yes, definitely. Yes. Yeah, Sharana ma'am, you want to add something?
No, I mean, I absolutely agree to that statement. We've been told summer they'll sweat, and during the rains, it's too wet outside. And I'm like, okay, so when is the good time? Your eye is already in trouble. Get it sorted. But yeah, it does bring a valid point. We definitely need to make people aware that weather has nothing to do with their cataracts.
Yeah, absolutely.
Yeah, so actually, that was my. You think the patient is ready for the surgery, but there are maybe the patient or the family is reluctant to undergo the surgery. So, how, as an optometrist, we should counsel that patient or the family to go for the surgery?
I agree with Dr. Zamindar in the fact that we cannot convince somebody who is not ready for surgery. And we don't believe in that either. It doesn't make sense. The patient would have CF at half a meter or 1 meter vision before the surgery, would come back with 6 vision after the surgery. But the first thing, you kind of would think they would come in and say, it's a great job and I see beautifully. But the first thing these reluctant patients will come and say is, at the corner of my eye over here, there's a little bit of irritation, and you kind of you don't know how to react. You kind of lose it over there. But you have to smile, nod your head, be polite, and say, yeah. Sometimes this happens after cataract surgery, and there's a little bit of the disruption of the tear film, and it'll settle down. And you kind of kicking yourself mentally because you actually did it for the good of the patient, and this is what you're hearing now. I think it takes a lot of energy and counseling before a patient goes in for surgery. I'm going to quote something that my dad said to us. My dad's an architect, so he always used to tell us, as many times as you want, do the drawings. Rip up as many paper sheets as you want. But once you start the building and you complete it, stop making changes, because it becomes twice as much effort, and you don't get the proper outcome that you want. Same thing applies to us.
Right.
Spend as much
Correct.
time as you need before the surgery counseling the patient, clarifying whatever doubts they have. I actually have asked patients, sometimes if they sound a little reluctant, I tell them, write down your list of questions, go outside, Write down all the list of your questions, come back in and talk to me, and I will tell you the answers. And they're like, doctor, but will you actually answer all the questions? And I'm like, if you know, so I practice with my husband, Dr. Balasubramaniam, and he actually loves people who ask some questions because he says post-op it's so much easier dealing with them because I can always say, remember I told you this is what is happening. And they're also happy because, oh yeah, right, you told us that. So I always remind them of that. Ask as many questions as you want, and we're quite open with answering, and we're quite happy to answer questions. So I think the most important thing is to be open and realistic about the expectations and the outcome of cataract surgery. Every patient that you operate or that is operated for cataract is not going to end up with plano 6/6 and N6 if you're putting in a multifocal or a EDOF IOL. There are going to be differences. So don't overpromise. We always tell them we are expecting that your vision will definitely be better. Whether it is the last line or 2 lines above the last line, we'll have to wait and see after surgery. Reading, we now have a disclaimer form which I actually give the patient, which says, I understand these lenses are for clarity for distance, not for reading. There are other lenses which would give me both distance and near vision clarity. Because most of these patients will come with nuclear sclerosis where they can read. They're very happy reading without glasses. And now suddenly after surgery, they come back and they cannot read. And that's the first thing. That's all they'll be concerned
Right.
about. The
Yeah.
fact that they had counting fingers before and now are reading 6/6 doesn't really matter. Or the fact that they had, 660 vision for distance, but could read. The could read is the problem over there. So I think it takes a lot of time. And I think it is important to explain to the patient what is going to happen to their eye and what is the outcome before we take them in for surgery. And
Correct.
every patient you're going to counsel is not going to come with perfect vision. Okay, and don't expect every patient to go in for surgery just because you tell them that it is the right time or it is the right situation where they need surgery. So don't get upset with yourself. Don't beat yourself up over it. There's only, you can only lead the horse to the water. Beyond it, it's up to the horse. Sorry, I'm
Right.
giving you a
Correct.
lot of, analogies, but
No, yeah, but that's actually true. Yeah. So we've got comment in the chat box from Mr. Rizwan. Okay, he's saying that I think patient counseling is most important part of the cataract journey because
I I do
that's how
agree,
we can really.
Rizwan. I do agree very much with what you're
Mm,
saying that counseling is the most important part. Um, Sometimes you will have to let the patient make. I think we still live in a democracy, so we have to let them make the decisions. We can't be dictatorship. We're not autocratic. We cannot push everyone into surgery. That's my take on it. I mean, if
No,
correct.
if
Yes.
Dr. Samina has something to add.
I just wanted to say that there are we have a team of about 12 eye doctors at Zamindar Eye Center in Bangalore where we work, and there is only one guiding principle when we are counseling for cataract is that first, never create a panic.
Mm,
I hate if somebody would create a panic in my life and say, get the surgery done now within 1 month or something, otherwise
Yeah,
you have this problem. I feel that that's not humane at all, that would not be like we are doctors. Come
true.
on, keep that in mind. You can't do this. So that's one thing. And second is that key think that the patient is your relative, your brother, sister, your family member, and what would you suggest? What is the best lens possible? And tell them that, so we would say that this is the first most suitable intraocular lens for you given your condition. And in case if you have any kind of affordability issues or something, maybe you can go for this. Never think that, oh, the patient will not be able to afford, this is what it is, and give another second option. In your mind, your perception of the patient's affordability might be completely wrong. So always this is the best suitable lens for you. Go for this. Of course, I'm not talking about the outreach camps where we really know that, this is what it is, and we would do that. But in general, when a patient comes to you, and sometimes, we have been surprised with our outreach patients also.
Yeah.
We would tell them that do this, and then they would say, no, 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 doctor, but I don't want my mother to wear glasses, and I have provision for this, and
Correct.
I would want the best. So these kind of things happen. So yes, I hope Mr. Rizwan now agrees that, after a while you have to let the patient decide. It's their right. Sometimes I tell my patients, I would go for a second opinion if somebody was operating on my eyes. If you're not
Yeah.
convinced, why don't you do that? Just go for a second opinion.
Correct. Yes. Yeah. Very well said. Yes. Thank you. I hope that has resolved the question for you. Yes. So yeah, moving on to you, Dr. Samina. What specific information in a referral note, is most useful for cataract surgeons? Of course,
So
from optometrists. I mean, what information you need it in a referral note? Yes.
basically, we would want the correct visual acuity, the refraction,
Mm.
uh, and we want to know if the patient has any allergies, any other comorbidities like diabetes or high blood pressure. If it's a male patient, then whether the patient is on any prostate medication, because prostate medication can cause some complication during the surgery. We should be ready. It can make the iris a little floppy, and so at during surgery we have to be ready for that. Moreover, if the patient is having any family history of glaucoma or already having glaucoma, then or diabetes or maybe diagnosis diabetic retinopathy, then we have to get them write down all those things without fail, because sometimes the patient does not let us know these things. But of course, uh, I think in general, I would say the vision, accurate vision, history of any allergies and ocular comorbidities, other comorbidities which are happening in the eye, and systemic conditions which the patient has should definitely help us for the referral if you're referring to an eye doctor. Yeah.
Additionally, maybe if they could also
Yes.
add what the vision expectations are, as
Right.
in, are they expect, because we've been seeing the patient in the community
Ah,
for quite a while.
absolutely. That what are their visual expectations? What are their goals
Ah,
for doing this surgery, and what is the outcome they are
yeah,
expecting? So if they're right, that's going to definitely make our life easy. Though,
more easier.
yeah, yeah, definitely, 101%. I never thought about it. Thank you so much. Yeah, yeah.
Yes, thank you for that. Yes, Sharana ma'am, over to you now. How do you approach, post-operative assessments? Now we get, we are the first point of contacts for the patients. They come to us, we do pre-op assessment, counseling, everything. The patient has gone to the surgeon. It comes back to us for the post-op assessment now. So post-op assessments, how do you, approach these assessments and identify patients who require re-referral? Like suppose sometimes it happens that patient is 6'6", in our everything is fine and 6'6" and 6, but still not satisfied. So would you reconsider, re-referral to the surgeon, or how do you handle such situations?
So, the first immediate post-op the first post-op visit is usually seen by the surgeon. We don't, I mean, the
Yeah,
optometrists normally don't
yeah,
get involved in the
right.
first day post-op, but the first week and the first month, we do the follow-ups.
Right.
They usually come to my OP. I have a look at them and then I decide what I want to do. Or if it is in an outreach, then a couple of my optometrists go there, have a look. They make a decision based on what has to be done. With regards to when I would re-refer, I think, okay, the procedure itself, the process of which I'm looking at, your post-operative assessment is just as important, if not more important, than your pre-operative assessment. Because your pre-operative assessment, even though you have seen it, before the surgery, the surgeon is also going to have a look at it, and then so there's always a double sort of, somebody else who's already looking at it. But if you're looking at the post-op assessment, which you're going to be doing either in the community or in your own OP, wherever you are, you are the one who is responsible for the outcome or the decision making at that particular point. Perfect slit lamp skills. I think that is something that I would Really, really recommend. If you have an NCT, get the pressures done. I at 1 week post-op, I do the refraction. I do a quick retinoscopy. I do vision. I do a quick retinoscopy. I may not do a complete subjective unless the vision is, a complete surprise from what I was expecting it to be. So if the patient has an ARMD, had 624 before and has only 618 now, my refraction is also showing what the expected target refraction was meant to be, like say, for example, a 0.5, then I wouldn't force the patient to read the distance chart with the minus 0.5 and try and do a huge refraction process there. But if this was a patient who had a healthy eye otherwise, no comorbidities, but is surprisingly not reading anything beyond 618 or 612, then I tend to do the subjective to just verify that the glasses are going to be adequate for giving me the improvement in vision, keeping in mind, of course, that I would have to look a little bit more carefully at the macula, look a little bit more carefully at where the IOL is positioned to see whether that could explain why the refraction surprise has come, unless it had something to do with the biometric. So my routine generally is the history, review of the medication and the timing at which they're using the medication. I ask both the patient and the attendant separately. It sounds like interrogation, but it is better to ask. My staff would be asking the attendant, I would be asking the patient. Basically, because a lot of times they skip medication and that can lead to, sort of post-op uveitis. So I don't want them not to do that. So we tend to be a little bit more kind of reiterative on checking on the medication use. The next thing is we also check on their cleanliness routine. A lot of them over here we've had where they've just gone back, they swim in, they just pour water on their heads, they're working in the fields within 1 week. And I normally tell them wait at least for a week to 10 days before you go back to doing all these things. A week at least before you wash your hair, because our water is not the best of the waters. So, just be a little safe than sorry. The third thing I would do is check the vision, check refraction, check the NCT if I have one there in 1 week. But if it is a 1 month post-op, even if I don't have the NCT, 80 is fine. Applanation tonometry to check the intraocular pressures. Fundus evaluation is done at both 1 week and at the 1 month post-op. We normally have optoms who can actually see the fundus very quickly, not somebody who's learning to see the fundus, because you don't want to stress this patient's eye. So we have people who know what to look for in the anterior segment, who know where to look for the inflammation, to see whether the pupils are fine, to look at whether the lens is looking all right, lens position is fine, look at the retina, see if the macula is looking good, see if the optic nerve is looking good, and overall is the patient feeling well. These are the things that we look at during our post-op visits.
Okay.
I think that's about what we do.
I just had to
Right.
say one thing from the because I also sort of work in infection control. So I feel that on the day 7, if the optometrist is seeing, if there is any case where you feel that the number of, according to your sun classification, uveitis, the cell and flare is more than what you would see in a day 7 case,
Refer back.
refer back. Like, just do it. Even if you have to overdo it, sometimes just do it.
Yeah.
Any point if you feel that the AC is slightly shallow, there's a
Bit
leaking
and
wound,
shallow.
there's a little leaking wound, refer back, because you might want to do a sedal, so but let the ophthalmologist
Yeah.
that, right? Because a leaky wound can lead to an endophthalmitis later, and a little excess reaction. Now I'm going to directly see the patient from day 7 to day 30. We don't want this patient to come after a week with a 10 days with a hypopion. We would rather catch it early and keep a closer watch over the patient. So if you can't refer immediately to ophthalmo, at least ask the patient to come after 2 or 3 days again. So these two things I think I would just add, but I completely am on board with what Saranya has said right now.
Thank you so much.
Yes.
Thank you.
Thank you so much for the answers. Okay, moving on to you, Dr. Samina. If somebody's mic is not on mute, I would request participants to keep your microphone switched off. And if you have any questions, you can put them in the chat box. We can take them up. We have two experts today, optometrist and ophthalmologist. So please make a good use of it. So yes, Dr. Samina, with the growing adoption of premium IOLs, what are there in market? So what role should optometrists play in discussing these lens options? Prior to the referrals to the patients.
Very,
They
very
should, they should not. What is your thought on
a
this?
very big role,
Yes,
and we would be very grateful to the optometrists, all of you, if you can do that little briefing in advance, because they get so confused when they come here. What is toric? What is EDOF? Why will
right.
it help me? Why I can't go for a trifocal? So all these kind of questions. I want to be completely independent of glasses, but why are you not offering me this lens? So there are a
Right.
lot of these things which we face, and if all learned colleagues, if you can sort of help us in that, that'll be really nice. First, make it very clear that cataract surgery is a safe surgery. Most condition it is bloodless, sutureless, and injectionless. Now we do these kind of, there are options of modern lenses which can make you independent of glasses if you decide that, if you want, if you are, but remember to tell them that only if you're suitable for that. There are some patients who might not be suitable for the most advanced lenses like trifocal, those who have a retinal condition or an optic nerve condition. Your doctor might want to just keep a monofocal lens or maybe an advanced monofocal lens, because these two lenses do not reduce the amount of light entering into the eyes, right? And whenever
Right.
there is a ocular comorbidity, if there is another existing condition which reduces vision, we become very greedy of light. We want all the light. We don't want to sacrifice any light, which can be sacrificed in a case of a trifocal lens or something like that, any diffractive lens for that matter. So this is something, if you can educate them, that's going to be very, very helpful. I do think that they should also be very clear, educate them about their own visual priorities and say, now when you go to the doctor, you please be very clear, I want this, and I want that. And especially, like Madam already said, Sharanya Madam, that if a patient is having nuclear sclerosis, is a myopic patient who is enjoying good reading vision, please tell them that if you're going for a monofocal lens, your reading vision will get compromised. And if you can
Correct.
go
Yes.
one step forward, then also explain them that you can request your doctor, even if you're going for a monofocal lens, to do something known as monovision, where one eye can be good for distance and the other eye can be good for reading. And there are good studies. In fact, Dr. Barrett in Australia has done a lot of work in monovision, and he says that that's as good as a trifocal lenses, though. So if a person cannot afford a trifocal lens or is not suitable for a trifocal lens, we can still do something like monovision if both eyes, again, for monovision also, I think the both eyes macula should be good, because otherwise monovision will also not work. Yeah.
Correct. Yes. And I think apart from options, knowing the brands or the what are the options for the IOLs, I think optometrists should also know the power ranges which are available for the lenses, because we are the ones who calculate the IOL power, and we might say we want to go for this lens, but the power is not available in that specific brand. So I think the power range is also sort of important to
Yeah,
know for the optometrists. Uh, yes.
absolutely.
Yes. Sharana ma'am, any thoughts on this? Yes.
Power range, whether we know or not, you can always check with the manufacturer, but you should know roughly what lenses do what, like Dr. Zamindar was saying, what lens does what work.
Correct.
What
Yes.
happens with the EDOF, what happens with the trifocal, what happens with a monovision. I think we need to know. I mean, whether we know the brands or not, that's a different story altogether, because you may know a particular brand, but the hospital that you refer to may not be doing that particular brand of IOLs, because they're
Right.
comfortable using a different kind of an IOL. So I think basic idea of what each type of lens does and what suits this particular patient. Your referral letter, like I said, could include a small note saying patient uh, tends to drive more,
Yeah.
not so much for near vision. So type A lens would suit. But if this patient is a type A personality, like for example, my dad, an architect who doesn't like even the slightest change in color or the slightest distortion anywhere, I've actually, we've implanted monofocal lenses because I know I would be a difficult multifocal IOL patient. Because for me, even the slightest change, I'd probably complain.
Yeah.
So, these sort of things are something that you can pick up because you're spending half an hour, 40 minutes with your patient.
Yeah, yeah.
Correct.
I love the fact that you brought this in, Sharanya ma'am, that about the contrast sensitivity,
Yeah.
There's a contrast sensitivity loss which occurs with some of the trifocal lenses, and we have to be very careful with this. Especially like in the beginning of the webinar, I was talking about refractive lens exchange. So some of the cataract surgeons have been, including my own self, have been doing refractive lens exchange for patients who have got high myopia or patients in the presbyopic group who definitely don't want to wear glasses for reading and they're not suitable for say refractive surgery like your refractive corneal procedures, and their age is above 55, say high hypermetropic or high myopic. You you can do it, but be very very careful what lens you're selecting, because for a person who has clear lens and now you're going to replace it with an intraocular lens, some amount of contrast sensitivity will drop, and they
Yes.
might be very comfortable in their reading, but if they come out and tell you that I'm not seeing as clearly what I was seeing before, that is something which is not a good idea at all. So be very careful. Caution is that if you're referring a patient for a refractive lens exchange, please be very sure about it. Please ensure that the patient is very very motivated to do that. Otherwise, do not
Correct.
send for a refractive lens exchange. Yeah.
Have we lost Harshada?
I think we have lost Harshada.
Yeah.
Maybe
So,
she'll.
ma'am, there's a question in the group. To whom would we counsel about multifocal IOLs?
So now, of course, better known as trifocal IOLs, and there are some other EDOF lenses also, which give almost good vision for reading. Like completely refractive lenses are in the market and now. Continuous range of vision lenses in the market. Anybody who is inclined to have not wearing glasses for reading, so
Mhm.
as simple as that. Those patients who are if you know that they are not diabetic or they do not have they can be diabetic but they don't have diabetic
That is the
retinopathy,
thing.
their OCT macula doesn't show any
Mm.
macular edema, and they are not a mild diabetic retinopathy for a person having the age of 65, 70, where I'm expecting that the diabetes is under good control and this patient is very less likely to develop a macular edema, I would still maybe refer. But a young diabetic patient of 40 years of age who does not have diabetic retinopathy, if he's very keen on going for a trifocal or a multifocal lens, you have to be very clear that he will have to really work on keeping his diabetes under control, and there is a risk of maybe a diabetic macular edema in the future, and where this lens might not give him very good vision. So
Mm.
this is what it is, that these are where you can refer all patients. You should know which patient to not refer for multifocal. So let's look at patients with glaucoma, diabetic retinopathy, and patients with any other reason with a macular edema. It could be a vein occlusion with macular edema. So any such patients, I think I would stay away from that. Type A personality, like ma'am was telling her father, who is very particular about this, I think do not. Anybody who is a night driver and
Yeah.
who is a habitual night driver, halos and glare, do not refer, please. So you can refer all, but remove these kind of patients from there. Yeah.
Right.
There's one question, ma'am.
How can optoms
Optoms play a role in reducing or managing post-surgery. Will including a routine foveal reflex help?
Cystoid macular edema can happen for any patient after the surgery, more common in diabetics. Now, most of us use some kind of NSAIDs now before the surgery, so that is helping us, and the incidence of CME is really less after surgery now. But if it does happen, it needs to be treated. Mostly, it resolves it by itself within 6 weeks' time. If it doesn't resolve, very, very rarely, then some intravitreal injection to be needed. But I don't really see a role of optometrist
No,
in this. I think there's really nothing you can do about it except pray that the patient you have referred does not develop CME.
doesn't develop it, and if they do, we can refer immediately. That's
Yeah,
all.
yeah, surely, surely, yes.
If you notice a drop in vision, the first visit that they have come to you, the vision is 6/6, but the next visit that they're coming to you, the vision is dropped, then I think you start looking for all these things and then you refer them back in. I refer anybody with a drop in vision. I don't think twice about referring drop in vision because, better to do it. Better safe than sorry. And a
Yes,
lot of these things, when picked up early, are manageable much more easier and works out really well. The outcomes are very good.
absolutely, absolutely agree with that, ma'am.
So,
yes. So
Harshada,
participants,
sorry, Harshada, we lost you in between, so I decided
yeah,
to just take
yeah,
over the question.
yes, no problem. My network is unstable because of the rains in Pune. Constantly
Okay,
raining since yesterday. So yeah, it's quite a little bit unstable. Okay.
right.
If participants have any questions, they can keep putting in the chat box. Meanwhile,
I just wanted to tell you one thing that I
yes,
might have to leave at 4 sharp. I have another
yeah,
meeting.
yeah, yeah. We'll finish it at 4 sharp. Don't worry. Yes. Okay, so I'll just quickly move on to case scenarios. You have to answer yes, no. Okay, so I have few questions for the optometrist and few for the ophthalmologist. So you just have to answer yes or no. And if you want, you can again explain your answer. Okay, so I would like to start with Sharana ma'am. Yes. So if you have a diabetic patient with usually significant cataract, okay. Would you refer him for retinal assessment before cataract surgery?
Fortunately, my surgeon does both, so I can refer it to one person who does both the assessments. But yes, I would also get the blood tests, the serology and the blood tests done and send them all together at one go because if we realize that the sugars are not under control, anyway, those have to also be brought under control. Retinopathy has to be looked for, and only then go ahead with the surgery.
Okay. A patient with moderate glaucoma and a progressive cataract, he reports worsening of vision. Okay, moderate glaucoma and a progressing cataract. He is reporting worsening of vision. Would you specifically mention the glaucoma status in your referral?
Yes,
Yes.
yes.
Okay.
Without a doubt, without a question, any comorbidity, whether it is ocular or a systemic comorbidity, has to definitely be mentioned. You
Correct.
are failing in your duty if you do not mention knowledge of what you already have and knowledge of the medication that your patient is using. In UK, where I was practicing before, this is an offense which could get me struck off the registers.
Okay. Okay, next is a patient is taking aspirin for a cardiac condition and is scheduled for cataract surgery. So, as an optometrist, would you advise the patient to stop the medication?
I wouldn't advise anybody to stop medication or start medication as an optometrist. I would refer them to I would have a chat with the surgeon and then refer them to their cardiologist who is given the aspirin. Sometimes they can decide to stop the aspirin. Sometimes they decide on giving heparin instead of aspirin during, the pre-op period. So that depends entirely on the cardiologist. And the number of days, again, depends on the condition of the patient, how long they've been on aspirin, and why they are on aspirin at that particular moment. So those decisions, please do not take them lightly. Please do not make them lightly. You can end up causing problems in circulation, which can be life threatening. Do not interfere. Do not cross lanes. Please stay in your lane. Refer the patient to the ophthalmologist and the cardiologist. You can do both. Refer to the cardiologist, get the opinion letter, and ask them to go to the ophthalmologist.
Yes.
I think that's the safest way to practice.
Yeah, right. Okay, and last one, should an optometrist promise complete spectacle independence to every patient considering premium IOLs?
Neither does my ophthalmologist or anybody that I know of. I don't think Samina ma'am either promises 100% spectacle independence, because ultimately every human body reacts very differently. We can promise spectacle independence 90% of the time. There may be 10% of the time, but they might need even, they may have N8, but they will want N5 sometimes. So you can't promise 100% spectacle independence.
Yes,
It's
yes.
like what we do with contact lenses or progressive glasses.
Yeah,
We don't
right,
say 100% on anything. So we always believe, promise the right amount. Don't under-promise, don't over-promise.
right. Yes,
What you're confident of, you tell them and let the patient make the decision at that stage.
right. Yes.
100% is God.
Yeah.
100% is God. God has given you your natural young eyes. So if you are an emmetropic, that's those are the eyes given by God. You cannot.
True.
We are all human beings. We would never promise 100%.
Correct. Yes.
So actually, there is something that we say during counseling. There are three people involved in the surgery: the patient, the surgeon, and God. Hopefully all three are working well together to give you the best results.
Absolutely.
Yes. Okay, moving on to you, Samina ma'am. Okay, quick questions. Yes. Does history of LASIK or RK make IOL power calculation more challenging?
Yeah, without fail. So we have to, though we are getting such patients and we use a different kind of formulas now, and we are able to calculate this, but yes, it does become difficult, and we always do a topography for such patients to decide the axis, and we never put a trifocal lens for such
Mm.
patients, right?
Right.
So always have a simple lens. A monofocal lens is always the best choice. You can put a monofocal toric lens, but never a trifocal or an EDOF lens. Any diffractive lens is not a good idea. Maybe a refractive lens you can still consider, but not a diffractive lens. And a lot of counseling for the patient is required before you, plan for the cataract surgery.
Okay. Yes.
लाती हूँ लाती हूँ क्या हो ना
And you use the true K formula?
Yes,
Or which?
definitely.
Yeah,
So the posterior corneal curvature is very
yeah,
important.
also taken in.
Yeah.
Yes. Okay. Would you expect an optometrist to alert you if a patient has significant dry eye before biometry?
Yeah, very important, because otherwise the patient has to first come and then we say, no, you come again and use these drops. The optometrists themselves can alert us and, start on some medications through us, and so that, when the patient finally comes for a biometry, patient does not have dry eyes, and the visit, again, the repeat visit is not
ला
needed.
रही हूँ ये
Yeah.
Okay. Yeah. Participants, please keep your microphone on mute. Yes. Okay. Would you consider premium multifocal IOLs in patients with significant retinal pathology?
Never, never. As I said, I'm very greedy for light for them. I want all the light. And with a multifocal lens, some amount of light is getting sacrificed. It doesn't enter because it is distributed among different zones.
Yeah.
Definitely not.
Okay, you have to choose one option now. What is more challenging, dense cataract with no fundus view or mild cataract with significant macular disease?
So both are challenging in their own way. If there is a dense cataract, what normally we do at our center is we do a B scan to ensure that the retina is attached. So we
Right.
at least have that clarity, and we tell the patient that your retina is attached. We don't know the exact condition of the retina, but at least it's attached. And we would do a kind of a perception of light and projection of light. So we know that it is, the retina is all. But B scan is mandatory protocol in our centers with a mature cataract to ensure that the retina is attached. And of course, with a mild cataract and a retinal condition, we will not be in a great hurry to do the cataract surgery. We will wait. Yeah.
And Dr. Sabina, last one. What would you choose, happy patient or perfect surgical outcome?
Happy
Happy
patient,
patient.
always. always.
Yes.
Happy patients. Happiness. We are in the business of sort of giving light and making people happy. So we don't want unhappy patients, right?
Right. Yes. Thank you. Thank
Harshada, Bala always says 6 by happy patient. It's not 6 patient.
you. That's great.
Nice. Good one. Good one. Good
Yeah.
one.
Okay, so as we have come to an end of today's panel discussion, and the conclusion of the actually the cataract series one session is pending with Dr. Balasubramaniam, and so that will be conducting maybe in few days. I would like to extend my sincere gratitude to both of our panelists, Dr. Samina and Sharana ma'am, for sharing their expertise and experiences, and of course, practical perspectives on cataract referrals and patient management. So today's discussion actually, reinforced the importance of timely referrals, comprehensive patient assessment, effective counseling, and strong collaboration between optometrist and ophthalmologist. Which ensures the best outcomes for our patients. So thank you both of you for being here today and giving us your valuable time and again your expertise. I would also like to thank all the participants for their questions and enthusiastic participation. We'll let you know about the third session soon once we finalize the dates and time of the session. So thank you all. Thank you, Dr. Samina, and thank you, Sharana ma'am.
Thank you. It was
Thank you so much. Thank you. Pleasure.
look after yourself. Thank you.
Thank
Thank
you.
you.
Thank you. Bye-bye.